It's rare for me to see all 5 of you in a room together sitting next to each other. I think this is really delightful. I think we have from the span really of fetal care and early born care to have MFM fetal surgeons, somebody from our echo group and our cardiovascular surgeons all here in one place is really nice, and you all form the core of the care group here. Doctors Najim and Phillips and really everybody mentioned that communication was a key component to the success of the program. And in order to avoid working in silos, which is easy for us to do, I think, I would say institutionally, you all have created an environment that has avoided that. If you could teach us all and comment on how you all work together, how to sort of destroy barriers that might exist in some institutions that may have existed here that you guys have overcome. I'd love to hear some insight into that.
I think it's really what this tagline says: every life deserves world-class care. And really from where the culture, at Cleveland Clinic helps define that. When you look at how the founding fathers started Cleveland Clinic, from the 3 real core values of understanding the disease process, training future generations, and studying the disease process. And I think really all of us are very geared on what's the best outcomes for the patient and how are we going to attain that. And for all of us, it's critical that we work together as a team. And when the patient is at the center of the decision making, that's the critical piece.
So in the decision making, when we look forward, is not only how to actually operate on the newborn after birth and get them out of the hospital. The very important question that we go through when we go through the decision analysis is what is the survival of this newborn after 10 years, 15 years, 20 years? And whatever we do in the first few hours of life, and it is in the first few hours of life, will determine how that baby is going to do for the rest of their life. And sometimes, even though that congenital heart surgery and surgery in general is considered technical all the time, most of the time, having said that, decision making is as important, if not more important, than the actual technicalities of performing the procedure, because you end up with sometimes an either unsalvageable condition or a dead-end road that you would not see in the first few hours. You may see it actually in a year or two, but then you can't get out of it. So I think the decision tree, as we go along with case conferences, when we all sit, as you alluded to, in one room, put all the brains together, is what is the survival hood of the baby in many years to come, rather than just the first few hours of life.
Pete, I thought that was a very good question, and I had to think for a minute there. How is it that we've been able to create such a good team? And I think the answer is twofold. I think one is at Cleveland Clinic. I think the 3 of us surgeons were attracted here because of the culture of teamwork that the Cleveland Clinic has always had. We're all pediatric surgeons focusing on newborns and fetuses and children, and that hasn't. It has a storied history, I guess, at the Cleveland Clinic, but it hasn't been ranked #1 like the adult heart programs have been. But I think we were all attracted here by the opportunities that lay with an infrastructure of teams that the Cleveland Clinic already had. And then also, as the director of the Fetal Care Center, that's really everything that it's about. It's creating teams. Historically, in caring for a fetus or an unborn patient, it has always been directed by maternal fetal medicine or obstetrics. but we think of a fetal care team as bringing in all of the pediatric specialists into the care of that unborn patient. And in fact, the maternal fetal medicine's care can continue after birth and creating a continuum of care to the mother and fetus from conception to late childhood. And integrating all the appropriate caregivers has been a key thing in creating an organized multidisciplinary fetal care center. And I think that's been an exciting thing that we've been able to develop here in the Cleveland Clinic infrastructure.
I would just add that from a non-surgeon's perspective, what we've done is very simply, we've gotten to know each other. We've talked to each other, we've listened to each other, and we kind of understand each other's perspectives. And through that, we've developed a shared vision of where we want to go and how we want to practice and that. And I think that's been key. It's very easy for me, if I have a problem, I can call Daryl, I can call Fran, I can call Alistair, I can call Dr. Najim. I mean, there's an open door policy here of communication amongst each other. And that takes some time to develop, but I feel like we've put that foundation in, and it makes, caring for complex situations much easier.
Great. We have some questions from the audience. So if somebody fetal anatomy, are we able to set up a virtual visit where some of the people in the room that are on this panel can all participate and opine? Is that something that we've established, is the question?
Yeah, I think it gets back to that initial question. I think one of the things we're looking to give the best level of care to every patient and also the care providers. And really the coordination and access to high quality care starts with being able to get the care providers together. Cleveland Clinic initiated virtual visits prior to this unfortunate times of the COVID. And we're looking to double the number of patients seen and really through virtual visits. We've embraced it as a team and find it a great platform. And it's a great way for all of us to get together and in one mind and speak to patients as well as care providers. And it's something that we're very easily to set up. We do it for international patients really at many hours during the day, which is convenient for wherever the patient or the care provider is.
I just want to echo the comment of Alistair. Previously, when we used to get an email regarding or a question in the email, we say, okay, let's set up a trip and bring in the CDs and so on and so forth. This is now history, and history is just like last year we were doing this. Now it's all changed. So everything is uploaded. We do a virtual visit. They are in their family room looking at the screen, and we're giving a consultation. And it's done. Now they are informed. They can make a decision whether they want to actually come in or not. So that has actually transformed our practice.
And to piggyback along that question, there's a question about whether that service is provided for fetal image review. Maybe that's for you, Fran.
Yeah, so I think that some of it we've always done on a small scale, and then some of it, as Dr. Najim was saying, has sort of, blossomed and may continue to blossom because of our current situation. So I think that we are always happy to review outside images, which we can do on a sort of physician-to-physician basis, or we can do on a physician-to-family basis, depending on what the situation is. And I think that if needed, can be a sort of shared service between maternal fetal medicine and pediatric cardiology. And I'd like to sort of add, I think it's what the others have said, that Often, I think if somebody is going to choose potentially care hair because of a potential need, then there is a reason to actually come here and maybe need to either be seen in person or have some further imaging in person. But a virtual visit or a review of outside images is actually a great way to sort of get introduced and see if it's a right fit and see if what we have to offer is either the same or different or in, you know, for whatever way better for that patient.
Great. One of the themes that was also hit upon was counseling. So look, all of you do a great deal of counseling, I would imagine, and the patients that you see. Dr. Ehrenberg, you had talked about the patient with hypoplastic left heart syndrome, which really becomes a marriage between you and the fetus and the mom, and it's lifelong. Can you all comment about how that piece works into your day-to-day? I can imagine how that would look, though. I think few of us probably appreciate the time that it takes and what really goes into counseling and the complexity of it. Can you comment on that?
Yeah, I can start if that's okay. So I think that that's really, I mean, if there's anything, that's the core of what we do. And it's actually an element of communication that you started off with as your question. And it's really the communication between us as the physicians and the medical team and the families. And I think there's really nothing more important than the counseling that we give. And so in my world, sometimes there's just this, we need to get a fetal echo. Well, a fetal echo is really just the tip of the iceberg. I mean, it obviously is the crux of it, and it's important because it defines what the anatomic defect is and things like that. But simply mailing that report back to, let's say, a referring obstetrician and having him or her have to tell the patient does almost nothing for that patient. What the patient really needs and what they're looking for is the counseling that we can provide them, the explanation of what this means for the rest of the pregnancy, the explanation for what it's going to mean during the perinatal period, both in terms of the delivery and the early management of the baby. And then as Dr. Najim alluded to, it's really what to expect for life. You know, I mean, they want to know, is my baby coming home from the hospital? Is he going to kindergarten? Is he going to college? Is he getting married? And those are the kind of things that I think we want to try to partner with the families and explain to them. And obviously not everything has a perfect outcome always, but the more that we can do to provide them with that kind of counseling up front with what we know and what we don't know and how we'll learn it over time, I think is what you know, enables us to care for them the best.
Any other comments?
Yeah, I think it's the commitment to lifelong care that we've been talking about for the patient, and it's really giving them a roadmap of what are our interventions and how are we going to help them over their entire lifetime. And it gets back to the whole concept of developing this congenital heart home for congenital heart disease patients, but it extends to the work that we're doing with maternal fetal medicine, the fetal surgeon, and really within that construct is that you have the baby and the mother. And it's how do you give the best level of care at that time, but giving them an understanding of what their life is going to be like, as Dr. Ehrenberg just discussed.
This question is for Dr. Cass, though. I think everybody can opine here. Dr. Cass, you mentioned a little bit about the history of laser therapy for twin and how it was controversial back in the day, and one of the strongest proponents was actually an opponent at one point, who happens to be one of our colleagues. I thought that was really a fascinating historical note. When tying this into you and your role here, looking at a lot of the work you've done here, I would imagine with that innovation comes controversy. How is that handled, particularly when you're coming to a program and tasked with building it? Doing things that maybe haven't been done institutionally before. How do you manage that, and how do you set expectations? You have 30 seconds.
That's that's an easy question. That's just, I guess, change management, right? Whenever you're doing something new or there's a new perspective, there's always, you know, the early adopters, there's the folks that are never going to change and never going to adopt, and then there's most of us in between. and it's best to just assume that everybody has what's the best interest of the patient at mind. Of course, there are conflicts. There are people worried about their own role and everything, but it's better to just assume the best, in my experience. It is interesting. As my career evolved and there were opportunities presented in front of me, one of them was to Dr. Murray's location in Seattle Children's, which I did to go visit. And I started talking about fetal surgery there, and it was a really interesting reception with lots of strong opinions, which I thought was really interesting. And a lot of it was lack of understanding of what the current evidence is and the current field is. And as we came here, there was lots of different input about that, and we just had to be patient, and I think just always assume the best and just to provide education. I told you that the trial, the mom's trial for spina bifida, published in 2011, and now it's 2020, almost going to be 21. What do they say in medicine? It takes 10 years before clear evidence starts filtering into practice. And as I've lectured and visited centers, I was surprised at neurosurgeons, neurologists, MFMs, maybe lack of understanding about the evidence that was in front of them, but it just hadn't percolated into their knowledge base. And I guess that's just true. We can't, there's so much knowledge out there now, we cannot be expert at everything. We're expert at a subset of things. We might be very good at a lot of things, but so we have to, I guess, rely on experts to help advance the science and advance the practice in our different disciplines. And I think we're seeing that now. And so I guess it's just change management is the answer.
If I may add, I guess we all continue to learn all our life. And if we close that door, this is probably should be the end of our career. I mean, this is truly, despite the thousands of patients we take care of and we've operated on or we've seen, every case deserves its own merits of looking at options, even though it looks like it is one of the other ones we've seen, but looking at options and hearing from everyone, whether it is in the room, in the center, or outside, published a case report. And this is how we evolve in advanced centers, is we continue to keep our doors open and our eyes and ears to the newer interventions. And unless we do that, we're going to prevent those patients that would benefit from this. Our duty is to vet these newer interventions and think about them logically, have case conferences, have all the brains decide what is the best thing, and then take it over or say no. But I think we should always continue to do this. And I have adopted this all my life. You probably know that, and I wish that I would never change and become one of the, people who would say, "Oh, I've seen enough of those. This is the way it is, and it's nothing else." I think all of us should embrace that idea that we always have to keep our options open, look for other ideas that sometimes comes in from a fellow in training that comes in and tells us something new that we could actually adapt and change the paradigm.